Good evening, everyone. Welcome to our March IPHA Town Hall. And as with continuing with our 2021 Town Halls, our Town Halls are proudly sponsored by QS1, and we thank them for their support for this series this year. I want to make sure that we just dive right in. We've got some really good, timely topics this evening, and I'm going to turn it over to our featured speaker this evening, and that's Dr. Lalita Prasad Reddy, who's the Assistant Dean for Student Affairs at Chicago State. And I'll turn it right over to you.
Thank you, Garth, for the introduction, and thanks to everybody at IPHA for having me talk today. I'm talking about something that I'm very passionate about: racism, inequity, and disparities, and kind of highlighting how these have become even more prevalent in the time of COVID-19. So again, thanks to Garth and Cody for having me today. All right, so at this time I have no conflicts of interest that I need to disclose. So the objectives of this talk is, at the conclusion, I hope that the pharmacist and technician attendees will be able to describe some health disparities associated with COVID-19 that have occurred during the pandemic as well as during the vaccine rollout, and discuss the impact of race and systemic racism on healthcare access and outcomes. So pre-test questions, and I would be curious to just kind of see this in a poll, what everybody thinks about these. So which of the following represents a social determinant of health? Select all that apply. A, race, B, education, C, housing, and D, access to care. So if you would kindly enter what you think the answers are into the chat. Okay, awesome. And then, which of the following represents reasons for inequitable vaccine distribution? Select all that apply. Lower access to pharmacies and hospitals within historically marginalized communities, overwhelming mistrust within the healthcare system among marginalized communities, challenges with technology and the digital divide, and then less awareness of the vaccine and its potential benefits. All right, so let's get into talking about health disparities and inequity during the time of COVID-19. So 2020 was a remarkable year for all of us, and beyond what we hear about in the news, which would be that it was plagued by a global pandemic that we haven't seen one in our lifetimes and are likely not to see another one in our lifetimes as well, there were other remarkable things that were kind of implicating and having consequences in terms of the pandemic. So there was a tumultuous civil rights movement. So we know that the Black Lives Matters movement, secondary to the horrific deaths of George Floyd and others, really reinvigorated a civil rights movement that hasn't been seen since the 1960s. Beyond that, there was a polarizing election. So we all heard the term that this is the most important election to vote for in your lifetime. Again, the tumultuous civil rights movement and the polarizing election were both founded in many of the issues of disparities and inequities among the populations. This brought to light the prevalence of inequities and disparities, and really COVID-19 showed the prevalence and the outcomes of these disparities within our populations. So the rough truth. Last week, New York Times, CNN, and several other news outlets stated that the United States has now had 500,000 individuals who have died of COVID-19. It's also estimated that now we've had over 30 million possible cases of COVID-19 that have been diagnosed. So that's averaging 1 in 10 individuals in the United States that have tested positive. Now, keep in mind that there are several more asymptomatic patients. So estimates are that that number could be potentially likely doubled as to the number of individuals who have been infected with COVID-19 during the pandemic started. What we do know is of the 500 individuals that had died of COVID-19 and the 30 million individuals who have tested positive for COVID-19, African American, Hispanic, Native American, Indigenous populations are much more likely to both be hospitalized from the disease as well as more likely to die. So while estimates range, according to the Center for Disease Control, the death rate in some places, and when you cohesively put these populations together, is 3 times higher than Caucasian white Americans. So when we look at the death rates cohesively and cumulatively for African American, Indigenous, and Hispanic populations, we are looking at death rates that are 3 times more likely than white Americans. When we're looking at hospitalization risk, we're looking at hospitalizations that, according to the CDC, are 5 times more likely than white Americans. So again, just bringing to light the disparity that exists in the prevalence of cases that exist. As everything that has existed with the pandemic since the beginning, equitable care and vaccine distribution continues to be a challenge. Now, I do want to preface that equitable care and distribution of resources to marginalized communities have always been a challenge. But because of the disparate proportions of hospitalizations and death in patients of marginalized communities, it's really now becoming a more hot topic in healthcare. And this is further fueled by, again, that polarizing election and, again, the civil rights movement. So this is just one estimate. So when we're looking at nationwide, when we're looking at deaths per 100,000 people by race or ethnicity through February 28th, nationwide, Black people in America have died at about 1.4 times the rate of Caucasians. When we look at Hispanics, we're looking at about 1.2 times the rate. When we're looking actually at American Indian, Indigenous populations, that estimate ranges depending on the source you go to, where they say that the death rate is approximate that of what Black people in America are experiencing, going up to all the way up to 3 times what people are experiencing. Again, this is all also dependent on how hospitals and organizations report their death rates, if they give a cause of death as COVID, or if they give a cause of death as another feature. So this quote is something that was just very impactful for me, because I think it's something that many of us would describe ourselves as. We're not racist. We don't see ourselves as racist, but all of us who continue to be complacent and allow marginalized communities to carry disproportionate prevalences and rates of conditions because of the societal and cultural factors that they live in. When we continue to be complacent, we have racism in us. So we are allowing institutionalized and systemic racism to continue to marginalize these at-risk communities. So this was a quote by Glennon Doyle that says, we all need to address our own situation, our own privileges, and the ways in which we have benefited from systemic racism. But we need to do so in a way that doesn't harm the movement or interfere with the Black voices that need to be heard. And we need to enter race conversations far too early, and we lead with our feelings and confusion and opinions. When we do this, we are centering ourselves. So we inevitably get put back where we belong, which is far from center. Again, the takeaway from this is many of us are going to not claim ourselves as racist, but when we continue to be complacent and allow marginalized communities to take the toll for disease and COVID, then we are allowing systemic racism and institutionalized racism to prevail. So with this, one thing that I wanted to highlight is there have been several stories about individuals not getting equitable care if you are from a historically marginalized community, ethnic minority. So African Americans, Hispanics, and Indigenous populations have all cited reports that when they entered the hospital system or they entered the institution citing COVID symptoms, they were either told that those symptoms did not align with COVID, they were told that they weren't sick, or they were sent home. And I think many of us know about that horrific story from Indiana, where a primary care physician kept telling the hospital staff that her care was not equitable as compared to other individuals with COVID, and she ended up passing. So this is pretty prevalent, and there are several more instances about this when we look at the literature. So I would like to take a second and actually have you guys listen to an excerpt that kind of talks about one individual's experience with the institutionalized setting.
People of color have been disproportionately impacted by the coronavirus. They're more likely to have frontline jobs that expose them to it, and more likely to have the underlying conditions that make COVID-19 worse. But the racism embedded in the healthcare system might also play a role. From member station KQED in San Francisco, April Demboski reports that some hospital systems are trying to fix that.
Back in March, Carla Monteroso went hiking in Utah with some friends. She flew home through the Las Vegas airport, and 4 days later, she started feeling sick.
I had a full, bad, dry cough. It was like my lungs felt really sticky, and my fevers were ridiculous. 100.4, 101.2, 101.7, 102.3, I believe.
She kneeled in the shower on all fours, ice cold water on her back, willing her fever to go down.
That night, I had written down in a journal letters to everyone, like, in case I died.
She was sick for another month. Then came a new batch of symptoms. Headaches.
I had shooting pains in my
and
legs,
sharp pain in her legs and abdomen.
I had seen so many of the reports of people having strokes around my age range about blood clots and being really afraid of that.
Still, she wasn't sure if she should go to the hospital.
As like women of color, you get questioned a lot about your emotions and the truth of your physical state. You get called an exaggerator a lot throughout the course of your life.
It took 4 friends to convince her that she needed to call 911. But when she got to Alameda Hospital, her worst fears were validated.
The doctor came in and said, I don't think that much is happening here. I think we can send you home.
Carla had a couple friends on the phone to help her, and they started asking questions. What about Carla's high heart rate, her low oxygen levels? Her lips are blue.
And he was like, I'm not doing this.
He walked out of the room.
You know, he comes in, he wants to talk about my friend's tone and like my tone.
Carla said she didn't want to talk about her tone. She wanted to talk about her health care. She was worried about blood clots in her leg, and she asked for a CT scan.
And he was like, well, you know, the CT scan is radiation right next to your breast tissue. Do you want to get breast cancer?
He didn't order the test. At nearly every turn, Carla says her concerns were dismissed. Her cycling oxygen levels, the machine's wrong. The shooting pain in her leg, probably just a cyst. Carla just wanted to get out of there. Her friends picked her up and drove her to UC San Francisco.
And one of the nurses came in and she was like, I heard about your ordeal. I just want you to know that I believe you, and we are not going to let you go until we know that you are safe to go. And I started bawling because that's all.
So there is more to that story. It continues to go on. And then she does say she felt validated in her care that she received at UCSF, but it is one of those accounts where states that there was an individual of an ethnic minority that presented with concerns of COVID and experienced racial bias in the institutional setting. And this did affect the quality of care that she did receive. So when we think about what are the drivers of inequity in our healthcare system, we really need to think about what drives inequity. Is it race or is it racism? And oftentimes we've used race in a construct. We've used race in a very lackadaisical way, that term. What is now being more elucidated is that race is a proxy. It's a social construct that was developed by anthropologists to artificially divide people into distinct groups based on certain characteristics, such as phenotype, physical appearance, ancestral heritage, cultural affiliation, cultural history, ethnic classification. So racial categories subsume ethnic groups. Now this dangerous practice is now very much being challenged because we know that race was just an artificially developed classification system. And when we look at the genotypes and the genomes of individuals from different ethnicities, African Americans versus Hispanics versus Asians, indigenous populations, Caucasians, there's very little diversity that exists in the human genome. In fact, two individuals from two different races can have more identical genomes than two individuals from the same race. And so really the inequities that exist are not a feature of racial issues or differences in the prevalence of disease states between one race versus one another. It's really the systemic racism that underlines this process. So the racism is the systemic subordination of members of targeted racial groups who have relatively little social power in the United States by members of agent racial groups who have relatively more social power. So what does then drive differences? We know that we frequently say, or we frequently hear that African Americans, indigenous populations, Hispanic and Latino populations have higher incidences of cancers, have higher incidence of heart disease, of diabetes, of obesity. But it's not an underlying biological genetic makeup that actually transposes those risks. It's instead the social determinants of health that focus around those populations. So social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And when we look at the 5 classifications of social determinants of health, we're focusing on the neighborhood and the built environment, health and healthcare, social and community context, education, and economic stability. So when we take a closer look at that, neighborhood and built environment, what does the housing situation look like? We know for patients of ethnic minority, they're more likely to live in urban areas. We know that they are more likely to live in multi-generational homes. We know that they are more likely to be exposed to crowded living areas. We know that they're more likely to live in institutions or housing complexes that may be plagued with mold or asbestos. When we look at health and healthcare, we know individuals of marginalized communities have not only less access and less direct access, but they also have less quality of care when they do enter the system. There are certain reasons that exist for this, but there's barriers with health literacy, there's barriers with competent care for marginalized communities. Social and community context. We know that they tend to have less reliance, or they tend to have more reliance on the social structure of society. So they require more on transportation circles. They require more on urban resources and community resources, food resources to carry out their normal activities of daily living. From an educational standpoint, we know their quality of education is not the same level as those in not marginalized communities, which leads to decreased health literacy and decreased investment in overall patient outcomes, which has been shown in trial after trial after trial. And then economic stability. We'll talk about the consequences of this social determinant specifically as it related to COVID-19. So when we look at these a little bit more closely, so social determinants of health, discrimination, we know racial segregation has been one of the reasons that individuals of these marginalized populations are in more urban areas, have more segregation. We know that healthcare access and healthcare outcomes can be compromised. We know that educational opportunities and educational access aren't the same. We know socioeconomic conditions are lower and housing is more urban, and they're more likely to not live in safe neighborhoods. We know there's deficiencies in access to care, deficiencies in access to resources, and deficiencies in access to jobs. When we think about transportation specifically, we know that individuals in marginalized communities are more likely to use public transportation avenues. Public safety continues to be a challenge. Social support and familial support tend to be not the same level because of the need for working individuals and working families. Social norms, exposure to crime, residential segregation, access to media and technology, and language and literacy are all broken down social determinants of health that have implications for why COVID-19 has a much higher prevalence in these populations. So now I would just like to take a second and discuss which social determinants of health have directly impacted either quality of care, access to care, or vaccine accessibility for marginalized patients during COVID. And you can just enter what you think in the chat. Certainly, Laura wrote transportation. So certainly transportations to and from appointments, transportations to and from vaccines, even in the fact that individuals in these marginalized communities are more likely to use public transportation avenues. They're more likely to be exposed. When we think about other risk factors, and I'm just going to go back a slide to kind of break down some of the social determinants of health and the impact on COVID. Obviously, we know that healthcare access and healthcare utilization are direct potential implications, but education-wise. So there is a lack of understanding about the vaccine. There's a lack of understanding in marginalized communities about what COVID-19 is and the consequences. Housing, more individuals were likely put in urbanized, crowded areas where they were therefore more exposed to other individuals. Access to community resources. So we know that individuals in marginalized communities during COVID-19 had there was about 40% that fell under the welfare line that stated they were unable to feed their families at some point during the pandemic. Unfortunately, food depositories and food banks were at much higher demand, and so there was lower access to those community resources. Access to jobs. We know that there was a lot of loss of employment during the pandemic that disproportionately affected the marginalized communities, and thus they didn't have the same potential. Transportation we discussed about. And then just simple things. So these individuals, many individuals didn't have access to the media and technology, so they might not have been aware of what was going with the pandemic. Language and literacy, health literacy. Other things are simple, is that these individuals in these marginalized communities share a disproportionate share of service level jobs. So grocery store workers, service line workers, teachers, and therefore they've been on those front lines the entire pandemic. So they have much more risk of exposure. So other factors that we do need to consider in marginalized patients is there's a lot of data and literature out there that suggests that historically marginalized communities, especially African American communities, hold a mistrust of the healthcare system. They've been marginalized in the past. They've experienced the cruel side of the healthcare system. We all know the story of Tuskegee. We all know the story of Henrietta Lacks. And so there is a lot of mistrust in the healthcare system from some of these historically marginalized communities. In general, evidence suggests that a lot of these ethnic minorities tend to have lower health literacy due to just lower, not the same opportunities in education as individuals who come from more privileged backgrounds. Individuals in marginalized communities aren't at the same socioeconomic level, so they avoid the healthcare system due to the high costs because they're not able to pay for it. So what did that lead to? So individuals wouldn't go they wouldn't go see their primary care physician or wouldn't go get screened when they weren't feeling well due to symptoms of COVID-19. So that led to a more severe presentation when they presented to the emergency room or to the hospital, leading to a higher rate of hospitalization or a higher rate of death in those populations. There was less screening, both due to the fact that there were less screening sites in areas of marginalized populations, but in addition to the fear of the risk of a positive test. Again, many of these individuals need to keep their jobs to be able to put food on the table and to provide for their family. So they can't afford that 14-day quarantine. Essential first-line job workers increased risk of exposure. So individuals that work at grocery stores, individuals that work at stores, at gas stations, just were working the entire pandemic and had a much higher risk of exposure. We know that there are certain populations that have increased risk of comorbidities. So we know that African Americans carry a disproportionate burden of asthma due to a lot, again, of the social determinants of health and those factors that increase their risk. But when they presented, if you had an obstructive lung disease, unfortunately, your prognosis was much more grim. And then there was an amazing article that came up about, the concerns about individuals that are classified as illegal immigrants and their fear of the healthcare system and their fear of seeking care for when they thought they had COVID because they were concerned that that would reveal their immigration status and that they would be deported on site. So there are a lot of factors beyond what we find as just very apparent to consider when we're thinking about these marginalized communities and why they're not maybe utilizing the healthcare system the way we want to. So systemic racism in healthcare extends far beyond the social determinants of health. And I just want to bring some other factors to play about other things that kind of penetrate healthcare systems and increase the risk of systemic racism. Obviously, we know this term implicit bias and unconscious bias is a hot topic in healthcare and even beyond healthcare. And it's really kind of biases that exist that one individual doesn't know that they are aware. So perhaps you don't feel you are a racist, but perhaps you have a implicit or unconscious thought that person A is less likely to show up to their follow-up versus person B because of their racial or ethnic makeup. And so that in itself is an implicit bias. And so that has consequences as it relates to healthcare. We know that there are a decreased number of minority professionals. So there is a disproportionate percentage of minorities in the healthcare system that work in the healthcare system, but again, doing service level jobs. When we're talking about professionals, there's a decreased disproportionate number going the negative way. And what we do know is that individuals trust and have higher trust in the healthcare system when they see someone like them. So an African American has a higher trust in the healthcare system if he's treated by an African American. And there's a lot of literature to support that individuals that have mistrust in the healthcare system may prefer or may seek out better care from individuals that have the same or align with a lot of the same background and experiences. And then something that I think we'll continue to hear about more as the literature develops is the practice of race-based medicine. So how does the practice of race-based medicine propagate systemic racism in healthcare? So how does the use of the avoidance of ACEs and ARBs in patients that are African American and hypertension propagate implicit bias and racism? How does the use or how does the adjustment of a GFR calculation in patients that are classified as African American propagate race-based medicine and imply systemic racism? Because it does drive care away from these vulnerable populations. So let's look at this as it relates to the current phase of the vaccine rollout. So we talked about inequities as it existed with COVID, and we're talking now about inequities. Again, they continue to exist as we are working through the vaccine rollout. So I think we can all agree that they're trying, but it's not a perfect system. So what we know is nationwide, there's approximately 15% that have been vaccinated with their first dose and about 7.5% that have been vaccinated with their second dose, so fully vaccinated. In Illinois, we mirror this pretty well. So 15.7% vaccinated with the first dose and 6.7% vaccinated with the second dose. Still, when we look at cities across the United States, the share of first doses going to Black residents is much smaller than their share of cases and deaths. So when you look at, when we look specifically, let's talk about Chicago because we were Illinois. So 22% of first doses, but they've accounted for 22% of cases and 39% of deaths in Chicago. In contrast, white individuals have had 46% of first doses, but have only accounted for 24% of the cases and 22% of the deaths. So again, you can see the disproportion and the disparity that exists with making sure that we are ensuring equitable vaccination of all populations. Now, there was a really good article that stated, you know, vaccine attempts to minimize inequities among individuals shouldn't be that, oh, we need to make sure that, you know, there's more vaccines available to Black individuals in Chicago. It's if they carry a burden that's 20% higher in death of COVID versus other population, then there should be 20% higher vaccines sent to those populations. So continued inequities in care. This was an interesting study from NPR, and the data here shows a number of states, and interestingly, they evaluated Philadelphia and Chicago, and so I wanted to share with you the Chicago data. So we know here that the percent of individuals who are vaccinated who are Black are about 17% in Chicago. And this is about a month old, so it's a little bit more outdated, but it does show the prevalence of the disparity. Interestingly, though, when we look at the percent of individuals that are 75 or older who are Black, we are looking at approximately 37%. And we're looking at approximately 35% of the healthcare workforce that is Black, but yet the vaccination rate really far lingers that. When we compare this with white individuals in the state, in Chicago, you can see that the percentage who are vaccinated are is about 50%, but they are a smaller proportion of individuals that are 75 and older and a smaller proportion of the healthcare workforce. And so again, this is not to state that a vaccine should go to one population versus another. This is simply just to illustrate that there is pretty massive inequity in terms of the percentage, or in terms of the populations that we are able to get vaccinated. So the other thing that we do need to consider when we're talking about populations and vaccination is, sometimes when we think about marginalized patients, we oftentimes think about racial, ethnic minorities, but we definitely we're very well aware that the elderly are often marginalized in healthcare. And there's a lot of emerging data about they're another population that's left behind in this vaccination effort. So I can say for myself, for my parents who are both healthcare workers, who are both physicians, and my in-laws who are both physicians, I had to help them set up their vaccine appointments. And these are educated individuals, but because signups are digital, individuals have to sit on the website, refresh it for hours. There's complicated sign-up methods. For my father-in-law, I know that I basically felt like I was signing him up for a loan, like I was having to verify his identity. And there's challenges with access to Wi-Fi and digital devices. Individuals in marginalized communities have less access to those devices. And then internet exhaustion. I think that if any of us have been out there and been trying to, if any of you have been out there and been trying to get somebody on a vaccine list or trying to get them signed up, you have internet exhaustion because it is such a frustrating process. When we're looking about other marginalized communities, the elderly don't have the same tech savviness as some of the younger populations, and we're looking at ethnic minorities. They again share a disproportionate share of service level jobs. They may not have the ability to sit at a computer, refresh it for hours. And then we certainly know there's transportation challenges. So there's a lot of people that don't even want to get on public transportation to go get the vaccine because they're scared of the risk of exposure. So homebound patients, how are we addressing those individuals that are homebound and not able to leave their residence? So what are some things we can do to decrease health disparities with vaccine rollout? So obviously increase access to home and community-based targets. So a lot of institutions in Chicagoland and even outside of Chicagoland have had targeted zip code interventions. So they look at the prevalence of COVID-19 incidents, hospitalizations, and death within a specific zip code, and they prioritize vaccine drives to go to that zip code. What is the challenge there? Is that a lot of the populations that are getting inoculated in those zip codes are not residents of that zip code. So we know that there are a lot of individuals that have actually live in downtown Chicago that have gone to the south side of Chicago in zip codes to get the vaccine because there's easier and more readily available in those areas. So that process does need to be streamed out a little bit. Community vaccine drives. Again, there's an abundance of data that suggests individuals are going to be more likely to obtain the vaccine if it comes from a community center that they're familiar with. So partnering with community service centers and religious organizations is likely to have some real large impact in terms of getting populations that are hesitant to get vaccinated. We want to enhance communication pathways sponsored by individuals of color. So there is an abundance of literature that there is a hesitance of the vaccine in the African-American community. So we need African-American ambassadors to actually go out and go into those communities and message it. So not the message on the television, not the message on the internet, because we know that those avenues are not reaching those populations, but going into the community, going into the Target, going into the grocery store, those areas that we know that those marginalized communities are present, and go in and break down those barriers. Break down linguistic barriers. So again, making sure that we have the vaccine information and patient education information available to everybody, not just individuals that speak Spanish, because there's far more populations out there that still feel marginalized. Break that digital divide. So there's been frustrations, and it's not a perfect system, and the digitalized system is the best way to ensure that there's the fastest amount of signups with the least resources necessary. But it's, again, not going to address the concern that we have in some of these marginalized communities who don't even know how to go on and what websites to access to be able to be vaccinated. Mobile vaccination drives are becoming much more common. So mobile vaccines. So let's take a van, go into a community that's marginalized, and get people vaccinated. And we need to continue to build trust. We need to continue to gain their trust. And this is not a one and done approach. This is going to be a process that the country and society has to do over time for marginalized populations. We have to make sure that they have that same access to equitable care, because when we talk about equitable care for all, we're talking about the same access to healthcare resources and the same ability to be healthy. And until those marginalized populations have those same access to resources and access to and have the same level of quality care in the healthcare system, it's not going to be fixed. So with that, we'll conclude with just the post-test questions. So which of the following represents a social determinant of health? So education, housing, and access to care are the social determinants of health. So again, race is a social construct. It's something that has been identified as anthropologists as a artificially developed classification system to try and differentiate populations, but it has very, very little biological basis. And then which of the following reasons occur for inequitable vaccine distribution? Lower access to pharmacies and hospitals, mistrust within the healthcare system, challenges with technology, and less awareness of the vaccine. And correct, this is all. So some take-home points. Health inequities have been prevalent throughout the COVID-19 pandemic. Although marginalized patients have a higher risk of hospitalization and death from COVID-19, access to screening, quality of care, and access to vaccination are all decreased. So methods to enhance equity in the vaccine distribution program include prioritizing high-risk zip codes and making sure they're utilized appropriately, increasing vaccination at community health sites and primary care sites. There is literature that suggests that individuals are going to be more likely to obtain the vaccination from their primary care professional or their pharmacist. So they're less likely to go to a community site where they're not going to get their answers or their questions answered, but they're more likely to be comfortable in getting that vaccine when they can talk to their PCP about it, or they can talk to their neighborhood pharmacist about it. So making sure that we get those vaccines where individuals can provide that individualized and personalized care to individuals that they're comfortable with is very important. We also want to decrease the digital divide and sponsor vaccine drives and mobile clinics. And it's not a perfect world, but we can continue to work towards equity. So with that, I'll take any questions, and thank you again for having me speak today.
Thank you. Any questions or comments for Lolita? Very good presentation.
Thank you.
Betty asks, what are some ways to mitigate the mistrust that certain marginalized populations have against the healthcare system?
So thanks, Betty. That's an excellent question. So it's definitely not a one and done type type thing. So part of the mistrust just comes from, you know, an example of the mistrust, why that mistrust exists is that video or that excerpt I showed you of that individual just where their healthcare provider didn't believe them when they came in. And so part of that mistrust is just having your faith and having open conversations with patients. I think that the other thing is improving access to care, improving community resources, and just not saying we're going to be doing them, but actually being on is one of those ways to improve. That mistrust isn't something that's going to go away overnight, but making those populations have, have the access to the education is very, very important as well. And I don't think that we do a great job of making sure that the access to education and information is provided through avenues that are, appropriate to some of the marginalized communities. So we know that several individuals don't have Wi-Fi access. Several individuals don't have cell phones. Several individuals don't have, they don't have those routes of communication. So it's just getting on the floor, getting on the ground, going to community health centers, even going door to door. So that's a little more challenging in COVID because we want to limit exposure, but patient education and education is the way that we can get through and kind of break that mistrust.
We had another question that was direct sent in. Are there any organized groups that are helping being ambassadors in communities right now?
There are. So a lot of these organized groups are not sponsored by governmental organizations. They're more grassroots organizations that are reaching out to healthcare providers. And if you're interested in getting involved, you can reach out to me through email and I can give you contact on some of these organizations. And they are going out to just community centers. They're going out to churches. They're going out, to areas in those marginalized communities and just getting the message out about the vaccine.
And I know, like here in Springfield, our local Black Lives Matter chapter is worked with the city of Springfield to start a COVID ambassador program, and so they're trying to help with that outreach here locally. Alexandra's put with gaining trust, transparency, and showing empathy. Oh, sorry, it's more of a statement than a question. Sorry about that, Alexandra. Never mind.
But I think, your point, Alexandra, is very valid. We need to acknowledge the racism that's existed. And we need to acknowledge that a lot of, our advancement in healthcare is because of the very cruel side of healthcare and a lot of unethical things that had happened 50, 60, 70 years ago. So, I think acknowledgement, empathy, and understanding for why there is fear and mistrust of that system has to be extended. So that's a good question, Rupesh. I think, there are reports of certain populations wanting one vaccine over another, saying, I don't want Moderna or I don't want Pfizer. But I think, and perhaps this is a bigger conversation, but there are some early studies that say Johnson & Johnson may be the vaccine of that's widely distributed the most because it is a one and done vaccination and we don't have to worry about that second dose non-adherence rate. So I think it's more not talking about, it's effective and worth. And I think, again, even though Johnson & Johnson, when we're looking at effectiveness rates, it's almost as effective in terms of preventing serious hospitalizations and deaths. And so that's ultimately kind of what we're focused on. And so I think that that's one thing that we can message to our patients.
Any other questions? All right. Well, thank you again, Lolita, and wonderful presentation and a great discussion by everyone in the chat tonight. And please reach out if you have any additional questions or comments. And we'll go ahead and pause the recording here so I can give everyone your code. All right. Let me get this shifted over.
Garth, can you put that code back up? Thank you.
No problem. Thank you, Emily, for putting that in there for me. So I just want to go ahead and go forward with the rest of our town hall this evening. We do have just, I know we've had a great discussion this evening, and I want to be respectful of everyone's time. So I'm not going to go through as much of the information as I was going to, but I do have some important updates that I want to make sure that you are aware of. As always, you know, we always like to look at the data, and I know that was shared earlier in the presentation. We're still, unfortunately, increasing, but we're starting to see some of the impact of the vaccine, and I'm being encouraged by that, but that still doesn't mean that we relent on our safety precautions. So we still have to social distance, we've got to wash our hands, we have to wear a mask. Here in Illinois, we're not seeing as much of a rise in cases. I know at least here in Sangamon County, I can speak for that we've seen a dramatic drop in our daily caseload as compared to 2 months ago at this time. We've also, all regions of the state are still in phase 4, which is excellent. And it's good to see that we've been now a month and a half in phase 4, and we haven't seen any spikes in COVID rates. It still doesn't mean we're not still having active infection. We're just not seeing the spikes that we were seeing in the latter half of 2020. When it comes to the vaccines, Illinois has been given 3.8 million doses, or at least has been allotted to the state. Only 2.9 million have been administered. And even in this long-term care population, we still have work. And I think that's one of the things that we continue to forget as we continue this, I think, race through the phases, is that we still have to go back to the populations in the very beginning, because we still didn't get everybody. Not all healthcare providers got the vaccine like they should have in phase 1A, in particular long-term care staff and long-term care health workers. Their actual uptake of the vaccine was very low. So please, those that are, you have peers that are in the long-term care sector, please encourage them and encourage their peers to please get vaccinated as we continue to go back into those phases and those patients to make sure that we don't leave anyone behind.
Garth,
yes.
A question. I've been looking at that kind of long-term care doses. Been the same number for, I don't know how many times I've looked at it the last time. Are they just not allocating anymore because they've still got 25% of the doses left to administer?
I think that's part of it. And what my question to public health, and I haven't been able to get an answer this week, is we know that with the original Walgreens CVS contract, they were supposed to go to each facility 3 times. And then after 3 times, I don't know who's supposed to be going back to get these individuals vaccinated. And that's what we need to be asking or getting an answer from public health about. Do we need now to be engaging additional pharmacies to go back into those facilities to help administer the remainder of these doses? Because we do know there's additional staff. We do know there's additional patients who have not received their vaccine. But I know, at least, and you bring up a good point, Dave, that that's why the number hasn't changed. Is I think the three visits have occurred, and then no one's come back to see them again, and that's what we need to have reuptake on from the department.
So is the allocation stopped, or they're just not doing any more until the administered doses go up, or do they even have a policy?
I don't know if they have a policy on it. I know that because a lot of the allotment for long-term care came directly from the feds. So my question would be, is this vaccine still with the original contracted pharmacies, or is are these vaccines with the state? So, there may be just vaccine that, Walgreens or CVS can't use because they're not allotted to go back or authorized to go back into those facilities, and they're in storage. And if so, then we need to go through the transfer process paperwork to get them out of those facilities and to the healthcare providers so we can get those vaccines administered. Good questions, Dave. Good questions. So our rolling 7-day average is 84,000 vaccinations. And I do want to thank those of you. I've seen a lot of increase of pharmacists, and including student pharmacists up in the Chicago area in particular, that are helping out with the effort. And I really want to thank all of you that have been out there helping with the clinics. I talked with some pharmacists earlier this week that spend most of their weekend drawing up doses at clinics up in Rockford. And so I do want to thank pharmacists all throughout the state, including our student pharmacists and technicians that are helping assist too. Because like we've said from the very beginning, this is an all hands on deck effort, and it's going to take all of us to help out. So there is a spot for each of us to step forward. And in that spirit is a reminder, we do still have room for people who are, if you know of pharmacy technicians who are wanting to immunize and be trained. We're hosting a training this upcoming Saturday, and we still have plenty of room for people to sign up. If you know of a pharmacist who is wanting to get trained, we have another session that is scheduled for March 20th. We just completed a immunization training of a number of pharmacists this past week, and I see a couple of them on the call tonight, so welcome. And congratulations again on getting your certificate. And so we do have those opportunities coming up, and we're not going to just be continuing to have these offered, so it is going to be based on demand. So we don't just wait for the next one to come up. So if you know somebody who's a technician who needs to get the training, get them in this weekend's training. There's not a lot of pre-reading that they have to do. I'm teaching the course, and we'll definitely go through all of the material until everyone is comfortable on Saturday. And then we'll do their virtual skills assessment. That's one thing we have completely shifted over to, both for the pharmacy technician and the pharmacist. They are completely virtual skills assessments now. So you can register for those programs by going onto the website. Just a little bit more into the inventory reporting. It's been interesting, with the 310,000 doses that we're seeing more in the community partners. And I'm hoping to see that number continue to spread, and we continue this divide so we can take this burden off of the local health departments. Yes, it's their job to be administering medical countermeasures, but they have limited staff. They're burnout. We know the National Guardsmen coming in to help out with some of these clinics throughout the state. And now we have a new federal clinic at the United Center in Chicago that's starting up, I believe, tomorrow. But we're going to see more and more of the inventory coming into community partners as the weeks come ahead. And I did include the race demographics, but Lolita covered that earlier. Just one thing to remember, APHA sent out a press release earlier this week, signing on to a statement that was also co-signed by the AMA and the Nursing Association, stating that we need to make sure we're redoubling our efforts to make sure that we are obtaining the race and ethnicity information, demographics for patients, so we make sure that we have proper tracking to make sure that we are getting into the communities as we discussed earlier. Again, just to show you where we're at with the population spread with the phases. Phase 1A, again, is about 880,000 people. We have about 7 million people into phase 1B, and now we have a unique term in Illinois called phase 1B part 2, which is actually what most of us would consider be part of phase 1C. But again, a lot of political pressures have gone on to advance people into eligibility, and it's great that we have more people that are available to get the vaccine, but that also puts now almost 8 million people who think they can get the vaccine and we don't have enough supply. And it puts more pressures on healthcare providers having to say we don't have enough appointments, we don't have enough supply, and it just frustrates everyone. So I'm encouraged by, the politics from the governor's office of trying to get people engaged in wanting to get the vaccine, but we need to be taking a more steady approach to the phases and making sure that we're not pushing people ahead when we don't, with their expectations, because we've got a lot of people really wanting the vaccine right now, and I'm still encouraged by those numbers, but we just don't have the supply. Now, we're hearing a lot of numbers that we're going to be getting 100,000 doses of the Janssen vaccine in the next couple of days and weeks ahead. So, supply is going to continue to increase, but we'll see where we're going forward. Just in a matter of time, we'll be sending out links from APHA. They have got some good comparisons on the Janssen vaccine, and we'll send those out to you. I want to be respectful of everyone's time tonight because I do have another major topic I want to talk about. But also do review and download our COVID vaccine resource guide from last week that was released yesterday. It includes a lot of information from the CDC and the FDA on the Janssen vaccine. Those brand new resources, we got them all linked in to the resource guide. So please take a look at that and educate yourself on the new Janssen vaccine. Now switching over to politics. All of you have received a farm flash to talk about our PBM bill. We have filed, both in the House and the Senate, our PBM reform package for this year. And we are really needing to go, we are definitely going to be going to bat this year harder than we did in 2019. And we were able to establish a successful legislative foundation in 2019. And the Supreme Court decision in 2020 cemented our movement. And that's what we're building upon. And that's why both of these bills are very important. We usually do try to start our major package bills in both chambers because as I talk with students, a lot of times the Senate and the House are like jingle blocks. You keep tapping on one of them until one of them moves. And so we are hoping everything will start in the Senate, but as things go, the House may move a little bit quicker. So, but the key point, what we need you to be doing right now is we need to be showing our outreach back to our legislators to let them know, thank you for your support in House Bill 465. Because remember, House Bill 465, which became law, passed both chambers unanimously. So we have tremendous support in the General Assembly for patient access and pharmacy rights. And so we need to continue to build upon that. And by doing that, we need you outreaching to your legislators and to your senator and your representative to say thank you if they were there in 2019. I know we have a lot of new members of the General Assembly, but those that weren't, we need you to say thank you for your support in 2019 for House Bill 465. We are wanting to make sure that we are continuing that success with Senate Bill 2008 and House Bill 3630. This screen here, and this is the last slide for this evening, this shows all of the House sponsors and the Senate sponsors that we had in 2019. If any of these individuals, and you'll start to see some emails from staff over the next couple of days, because we're going to be particularly reaching out to members in these districts saying, please get these co-sponsors back on the bill immediately. March is very essential. We have to get the bill out of either the House committee or the Senate committee by the end of this month. And the House and the Senate are already starting, they're doing a lot of things, they're doing everything virtually. So it is a lot harder process to get bills through. This week has been an interesting experiment in watching the committees, and it's been tough for them. And so we have to make sure that we are ready to go when either Leader Harris or Senator Kaler say they're ready to move the bill. We have to be there with the support and with the co-sponsors and with you guys submitting witness slips. So just keep an eye out for farm flashes. We're going to hopefully have some additional advocacy tools for you here in the coming weeks. So please do reach out to your members this week. If you don't do anything else tomorrow, please reach out to your senator and your representative and ask them to support these two bills. This is essential as we go forward. You know, we talk about the increasing of pharmacy deserts and how that has an impact on patients. We talked about that earlier tonight. A lot of that we can put back directly to the continued abuses by PBMs on the pharmacy, because that puts a continued pressure on pharmacies not being able to remain accessible for patients. We've talked about the number of studies that have been done on pharmacy deserts going all the way back to 2014. In particular, that study looked at the city of Chicago on the west and south side. And a lot of that had to do with the fallout of the mismanagement of Medicaid. And so a lot of this really builds on each other and has to do with the need for PBM reform. So we really need to make sure that we're pushing on this year. We're going to be working on a lot of other legislative initiatives, to at least 2 other major initiatives, but this is our key focus. And we're going to need everyone to help us out to make this a success. So I know I really preached on you here for a couple of minutes on that, but this is vitally important. So please make sure, I know I'm really talking to the choir with a lot of people that are here on the town halls every month, but it's really, if you can help pass that along to your peers, anyone that you know that's a pharmacist, a student, or a tech, if they ask them if they're helping getting support for this bill, and if they don't know what you're talking about, put this talking point sheet in their hand. They have to know what we're doing and how we're helping keep the profession alive and how we're keeping patient access and cost-saving patient access alive in Illinois. And that's what we're going to be doing with this package. So I'm going to step back and open it for any general questions or comments from members of the town hall tonight.
Garth, I spoke to Janet Yang-Rowe. She's the Democratic member of the House from the 41st District, and I shared this paper document with her already. And she asked me a few questions. I talked to her about it before the election, so she has heard some of these things already from me before. And I said, if you want further clarification when she's in Springfield, she can talk to you also. And I've shared your email with her. But she was very excited in knowing more about it. Her name is Janet Yang-Rowe.
Great. I will make sure that either myself or Brian reaches out to her to clarify any of her outstanding questions tomorrow. We reached out to about 30 various patient organizations to ask for support today, and we were I was very welcomed by the numerous early supports and responses we got back from a number of those organizations. And you'll start seeing them start to push their support more visibly over the coming weeks as well. So we're helping build a big coalition around this effort. Hank, I see you have your hand raised. Go right ahead, sir.
Just an update from the Skokie MRC. We are being severely hampered by lack of supplies, lack of vaccine. Tuesday, I helped prepare the syringes that we had available for this week, and we prepared 734 syringes, which means in the clinics this week, we're only going to inject 734 people. And so we're being, as I said, we're just being hampered by no supplies.
Well, Hank, I definitely appreciate you sharing that. I will pass that along to public health in our conversations with them. And I really want to appreciate you stepping up. You've been a longtime member of the MRC there in Skokie. And I see another couple on here like Alan Graver, who I know has been very active in MRCs and helping out with a lot of these efforts as well. So thank you for taking time out for helping out. And I'll definitely pass those along to the department. Any other questions or comments? Sam, I see your comments about the Peoria MRC as well, and I will pass those along.
Garth, that one NDC number you had shared with me for the syringe, when I tried to order Cardinal and Merisource, they were both out of that NDC number, out of stock, as of yesterday.
Oh, no. And that doesn't surprise me. I know that I know when we were buying supplies for the trainings a couple months ago that we had to make some alternate selections as well. I know the companies are trying to get back up, and I know hopefully, because I believe President Biden did enact the Defense Act on these supplies, and so that should help with making that a little bit more expedient here, hopefully over the next number of weeks. Any questions or comments? Well, just as a reminder for those that if you haven't registered, virtual APHA meeting is next week. And as a reminder for those in the Illinois delegation, we'll be talking about House of Delegates next week. Starlin, do you want to put in a shameless plug for your session you have at APHA next week?
Come to my Sunday at, I guess it's 1:30 Central Time. I'm talking about telehealth platforms. It's a 3-part series. I'm doing part 2 along with a young federally qualified health clinic pharmacist from Ohio. We're going to talk about how to set up and pivot and run toward the fire as we did in COVID. So it's pre-recorded, and then we have live Q&A. So it'll be fun. There's a bunch of people speaking. Sneha and Andrew are doing a diabetes update of some, and Jenny, are you speaking? Who's all speaking? Miranda, are you speaking?
No, but Kelly Gable from SIUE is presenting, and
awesome program Kelly Gable's going to give. I reviewed her abstract.
Who is our alumni from Ohio? And Diana Jason.
Diana Isaacs is doing 2 programs on CGM and digital technology. It's huge.
Yeah, it's really good to see, you know, when our IPHA members are continuing to blaze pathways on the national stage, and also during next week. So next Thursday, I will be stepping up. Speaking of taking on the national stage, I will be inducted as the president of NASPA, which is the National Alliance of States Pharmacy Association. So that'll be a great endeavor over this next year to help represent IPHA on a national stage. And I'm great to have that honor from NASPA. Sam, you were like, are we going to be able to link to tune in? I don't know if we'll have that. I have to look to see if that's going to be a public meeting link or not, but we'll see. But if not, we'll definitely have some pictures of it. So any other questions or comments for the good of the order? All right, everyone. Thank you again for letting us go over. And we'll see you all in April. And again, remember technician training on the 6th pharmacist training for immunizations on the 20th, and get those co-sponsors in. I'm going to be really harping about that over the next couple of days. You're going to be seeing a lot of that. So get those co-sponsors so I can lay off of everyone. So thank you. Have a good night.